Thank you, Dr. Ho, for the very kind introduction, and thank you, Professor Wang, for the very kind invitation. And very nice to see all of you here today, and to share how we could do to transform voice and transform life. So today, my topic is transoral injection laryngoplasty. So I will give a very brief introduction for the history of injection, laryngeal injection first. So you may know the first injection was done in 1911 by Brownings with paraffin. And subsequently, we used Teflon for injection by Arnold in 1962. And these are the earliest laryngeal injection record in the literature. And at the time, they are using Teflon injection and performed under general anesthesia because of the improvement in general anesthesia at the time near 1970s. But subsequently, we found that the laryngeal injection with Teflon could create complication, namely Teflon granuloma. And the development of this serious complication could range from a few months to many years, up to 18 years. So after that, together with the new treatment options for patients with unilateral vocal fold paralysis, like type 1 pharoplasty, as introduced by Professor Ishiki. So laryngeal injection has become less popular in the time in 1970 to 1990s. But we can see in 21st century, with the improvement in filler injection material, and also with the improvement in endoscopic technique with all those trip-tip endoscope, we are performing more of these laryngeal injection again. And you can see in the early 21st century, in the US voice centers, the number of injection was increasing. And not only the number of injection, but also the technique, the way we inject. Previously, we inject by general anesthesia in the operating theater, but now the trend shift from the OR to the office. More and more of these cases are performed under local anesthesia on awake patients in the ENT clinic. And the injection indication also expand. Previously, I think most of the cases are performed for vocal fold paralysis, but now we understand there are different causes of different voice pathology that can cause glottic insufficiency, including paresis, more in aging people, vocal fold atrophy, and sulcus vocalis. All these causing glottic insufficiency we can also treat with laryngeal injection augmentation. And we have different kinds of injection materials, ranging from some short-lasting to a moderate to long-lasting material. And I also know we have another speaker who will also talk about autologous fat injections subsequently. So you can see there are a lot of injection material that we can choose from. So the different approaches. Percutaneous approach should remain the most popular approach used by most of the physicians over the world. And we can approach through the thyrocartilage, coagular membrane, or thyroid membrane. And sometimes we can also use EMG guidance to do the percutaneous injection, as later Amanda and we will introduce to all of you. And I know Professor Wang is also using this approach in Taiwan. Some people use the transnasal approach through cannula through the working channel of endoscope. Some drawback is that some filler material are just so thick to block the injection cannula, so it seems not to be a really popular injection technique. So transoral approach, as I've mentioned, and this is my favorite approach, we can perform it either under general anesthesia with the patient under GA, and we use a direct laryngoscopy to inject, or we can do in office on an awake patient with a curved transoral needle. I must emphasize that all these different approaches have their pros and cons. And I always remember the example Professor Wan mentioned previously. It's just like different flavor of ice cream. You have different flavor to choose from, but you can have your favorite. You can have 1, 2, or 3 favorite, but know your favorite so you can choose from. And my favorite approach is transoral injection on awake patient. So I learned this technique during my overseas training in the United States, and so I want to practice this technique when I return to Hong Kong. But like many other Asian countries, we have a problem to use this approach, and most of the time that we perform this approach in the general and under general anesthesia in the operating theater because the instruments are readily available, but not for the transoral curved needle. So some people believe that the transoral approach is a bit technically demanding compared with some other options, and because you need to manipulate the needle through the very sensitive oral cavity and oropharynx. But I can reassure you that with just a short learning curve, you should be able to master the skills. And later, I will also share with my humble experience on the way to perform successful laryngeal injection by transoral route. So go back to the reason why this transoral injection is not too popular in Asian countries, because we don't have these single-use injection kits, which is readily available in United States and also Europe. These kits provide the filler for injection, as well as 2 types of needle for the physician to choose from. So if the physician want to do a percutaneous injection, they can use the attached short needle to do it. If you want to do a transoral injection, they have a long needle for you to bend to use it for awake injection, or remain strict to do it under general anesthesia. The needle is a bit special in the way that the shaft is thicker in caliber, while the injection part, the needle tip, is very thin in caliber. Because you have to have a shaft caliber to give the strength for the needle to go through the oral cavity and also the oropharynx of the patient into the larynx. But you will still need a very, very fine needle for injection into the vocal fold. Otherwise, the filler material will regurgitate out after your injection. So in Hong Kong, we don't have this single-use kit. So we use the filler mainly for facial plastic augmentation. And then we source for transoral injector to perform the injection. So this is the instrument that I use in my center. And you can see this is the injector. And also this is the needle. The needle is single-use. You use a new single-use needle for individual patient, but the whole instrument can be reused. And we have to change the filler to the injection syringe before we do the injection. So a little video to share how I do it. And you can appreciate how we can see the whole needle going through the oral cavity to the pharynx, and everything is under direct vision. So anesthesia of the patient is important. You have to make sure the patient don't have a gag reflex before you can perform successful injection. So I'll use a drip catheter and systematically drip local anesthesia to the pharynx and larynx instead of giving spray or puff to the oral pharynx. So you can see after anesthetized, the patient have less swallowing and choking reflex. And now we can use the needle, go from the oral cavity down to the larynx. And the needle, you can see the whole needle, and you can precisely select your site of injection, which I will perform just anterior to the vocal process, and also in the middle part of the membranous flow, more laterally. So you can see I will try to lateralize the false cord and do the injection more laterally to avoid inject to the rinky space. So this is the immediate result during the operation. You can see the closure of the glottic gap with slight hypercorrection of the gap. So a few minutes to share some technical tips for successful injection. So firstly, adequate anesthesia is mandatory. Apart from the use of drip catheter to drip down to the throat, I will also use cofenicane to the nose to decongest the nose and also to numb the nose, as well as cytokine spray to the throat. This is particularly important to spray over the soft palate, uvula, and the tongue-based region because this is also very sensitive part. And in younger patients, this manipulation of the needle from the oral cavity to the oropharynx is the most difficult part of the injection, especially in fat patients with coexisting obstructive sleep apnea. Their tongue position would make it difficult to pass this small gap into the oropharynx. Secondly, I've mentioned this is the anesthesia used by a drip catheter. And make sure you have a good endoscopic view. You should have a very good assistant to help you to manipulate the endoscope. And I will try to use a suction unless absolutely necessary during the procedure, because the suction force could also irritate the patient and trigger some swallowing or gag reflex. And initially, the scope placement is also important. I will usually place the scope just over the velopharynx so that I can see the uvula in the 6 o'clock of my endoscopic view. In this way, the endoscope would provide the illumination to the oral cavity. So I don't need a headlight. I depend on the endoscope to give me a clear view of the pharynx to put in the needle through the mouth. And most of the time, I will make sure myself, the injecting surgeon, and the patient are at the same level, so that I can see clearly where to pass the needle initially horizontally into the pharynx before I turn the needle downward. And I will try to get some point for me to rest the needle because the patient is awake. Most of the time, when you are putting in something into the mouth, they have a tendency to move their tongue, to elevate their tongue. So try to find some point that you can fix your needle and they cannot move the needle. I will use the gap between the two upper incisor, and also after the needle goes into the pharynx, I'll use the epiglottic tip as another point to rest the needle. And one more important way to do the injection, especially the more anteriorly, is that you have to adequately abduct your shoulder over almost 90 degrees. In this way, you can actually turn the needle more anteriorly. Sometimes my trainee during their initial training, they want to do the injection more anterior. I don't mean the anterior commissure, but even just the middle part of the vocal fold, membranous vocal fold, you need some maneuver to advance the needle. Otherwise, the needle would be tilting posteriorly, and you cannot do a good injection over that area. And as mentioned, I will do it in the just more lateral side to avoid injection in the rinky space, which may cause very low-pitched rough voice to the patient immediate after the operation. And do manage the patient expectation before and after operation. Clearly explain to them discomfort would be possible during the procedure. And also let them know that immediate after injection, because we tend to over-inject and also possibly some edema, swelling during the operation could also cause a worsening of voice temporarily immediate after the injection. Do let the patient know first. And explain potential complication after injection. Sorry for the typo, not Botox, because I also do a transoral Botox injection. So sorry for the typo in the last slide. So finally, just some humble experience on my experience over 800 injection in my center. So we have performed 83 injections for the indication of unilateral vocal fold paralysis, and I can have a technically successful injection in 95%. So these are the demographic data of the patients. Most of the time, the vocal fold paralysis is over the left side, and most of the time, the patient is having the pathology either due to malignancy or iatrogenic. And you can see the injection obviously can improve the voice quality of the patient, as evident by the voice handicap index 10, and also the maximum phonation time, both are statistically significant result. So this is my team. So we are not a big team, but we work together to achieve our goal. And if you are interested in transoral injection and if you want to observe some injection, welcome to contact me anytime. And we have a designated voice clinic to booth injection regularly. So thank you for your listening. And again, thank you for the very kind invitation for me to share my experience here. Thank you very much.
So thank you, Dr. Kwan, for your excellent presentation. Are there any questions from the audience?
Dr. Kwan, welcome to Taiwan, and thanks for your excellent talk. I'm also a big fan of transoral injection. That's my favorite too. And I was wondering if you have a direct telescope, like a 70-degree telescope, then you can spare the nose.
Yes.
Yeah, that's my favorite way, because in that way I don't need a resident doctor. I can do it solely by myself.
Yes.
Yeah.
Yes. I have another colleague from Hong Kong. They are also doing this way. And so for the tongue part, do you instruct the patient to hold the tongue by him or herself? Yes. My other colleague also do that way. Yes. I'm aware of this way. But I found it a bit difficult to really use a rigid telescope, especially when we are now performing more stroboscope by the festival scope. So still, I would like to engage my colleagues to inject with me with a team approach with 2 persons. But I appreciate your sharing. Yes, it's a very good way, especially when you have a sole practice. And do you also use the same injector in Taiwan for injection?
Yes, yes. And I agree with your findings that the Medtronic injector, sometimes it will go way too posterior. So there is a bendable needle, which you can make it over 90 degrees to inject it into a more anterior part.
Right.
I totally
the needle is
agree.
it a constant needle? I mean the shaft of the needle and the needle tip, is it same caliber, same?
No, the shaft is more strong and the tip is thinner.
Oh, really?
Just like you said.
There's
But
another needle.
The best part is that's malleable, so you can bend it according to the tongue shape. So
well, we should have more discussion. I think this is also a very good option if it's available in
and I
Taiwan. And also
agree with your finding that it's more tough for younger patients.
Yes.
And it's easier for older patients because their sensation tend to get
and also
weaker.
For irradiated patients, when the sensation is diminished by the irradiation.
Totally agree.
Yes.
Thanks.
Thank you.
So, Jimmy Wang.
Thanks. Thank you for your excellent speech.
That's just my humble sharing.
Okay.
Yeah.
Compared to the transneck injection, transoral means you will need to more HA.
Hyaluronic acid.
Yeah. So generally in Taiwan, the HA is about 1 cc, and maybe it cost about maybe not so
yes. So the test base would cause some wastage. In fact,
if you do the transoral injection, how many cc HA? Maybe 2 or 3?
Usually, I need sometimes 1 if I'm performing for bilateral injection for atrophy, because I would just really inject a little to avoid. But for patient with big gap, I may actually select open pharoplasty. So most of the time, one should be okay. And from my experience, the death rate is not that much. It's about 0.1 milliliter compared to the loss when you transform the filler from the filler syringe to the needle.
Yeah.
Sometimes I can lose up to 0.2 mil. But most of the time for a patient with requiring injection instead of open surgery, 0.5 to 0.6 should be adequate. And
So do we have further questions?
Thank you very much for your excellent speech. In our hospital, we used to use transoral injection for glottis. However, some patients, especially for those with OSAS, sometimes they have a big tongue. And it's not easy to do this transoral.
yes, exactly.
So is there any tip for this kind of patients, or when will you consider, oh, this patient is not suitable for the office-based procedure and I should do it in the operating room?
Okay, the first question, I would try my best to make sure anesthesia is adequate, because most of the time the tongue even is bulky, but if the patient could relax, would really relax, you could really find a slit between the tongue and the soft palate to manipulate through. And also the illumination by the endoscope is also important. So really, I would ask my patient to totally relax and just let me hold your tongue without use any force in your throat. Sometimes you can find more space for you to manipulate the needle through it. And I think, I'm sorry, I missed your second question. You mean in that case, what will be my choice?
I mean, which kind of patient you will think, oh, this is not a good candidate for office-based surgery, and I should do
Actually,
the
I will
injection?
perform all for office space, but I will start with transoral injection as my favorite approach. If it's really failed, but I would say it's just a few cases, I will do the percutaneous approach. I will do the cricothyroid approach. Some which use the higher approach with band needle, and but I myself is a bit worried about the bleeding risk and also the more soft tissue to manipulate through before the needle can go through the epiglottis and visualize. So I myself which use percutaneous cricothyroid approach as my salvage.
So any further
Thank you.
questions from the audience? So I have two questions. So
Thank
do you also inject CAHA with transoral approach?
Inject, sorry.
Calcium hydroxyapatite? CAHA?
Hydroxyapatite. Yes. Yes, I'm doing.
And do you face any difficulty in injecting because of the consistency of the filler?
No, not a
No.
problem. Usually, for patient with initial success, I will do calcium hydroxyapatite in the second approach for a longer duration. Yes, no problem with that.
And so you mentioned in your success rate of approximately 95%, and in those remaining 5%, what kind of difficulties did you face
I
during
think
injection?
it's just mentioned.
Yeah.
I cannot manipulate through the needle through the oral cavity to oropharynx. And another patient, I have a flip back epiglottis, which completely touching the posterior wall. So these unfavorable anatomy case, I will do the percutaneous injection.
So it's more the shape of the larynx rather than the gag reflex of the patient.
The shape of the larynx and also the tongue base, the bulky tongue base. Yes.
Yeah, thank you.
Thank you.